Good evening, everyone. Thank you for joining us for today's webinar, Living with Chronic Lymphocytic Leukemia, organized by the Florida Society of Clinical Oncology, or FLASCO. FLASCO is a member-supported state society that focuses on supporting and representing the oncology workforce of Florida. Together, FLASCO is the voice of oncology in Florida. Many of the individuals presenting and participating in this webinar are members of FLASCO, and we appreciate their support. My name is Dr. Hayder Saeed. I'm an associate member at Moffitt Cancer Center in the Department of Malignant Hematology. I will be serving as the moderator for today's webinar. Our topic today is living with chronic lymphocytic leukemia, or CLL. Our oncology experts will discuss the disease itself and treatment options, and then move on to more individual focused area, including support for caregiver, advocacy, and CLL resources. I see here questions about the volume is low on your end. I'll have Amanda address this question.
Hi, Dr. Saeed. I can hear you pretty well on my end.
Okay. Before we begin the presentation, we'd like to thank Pharmacyclics and Janssen for supporting this webinar and making it possible for us to share this important information. I'd also like to let everyone know that this webinar is being recorded so that those who are unable to attend can view it at a later time. Please note that your lines will be muted for the duration of the webinar. Towards the end of the meeting, we will host question and answer Q&A session, and we encourage you to submit questions or comments via the Q&A chat at the bottom of your screen. We will discuss as many questions as time permits. I'm honored to introduce our amazing group of panelists. I will briefly introduce them, but please read their impressive bios in the meeting material that we emailed to you. Now I'd like to introduce our panelists. First is Dr. Alan Kerr. The second, he is a hematologist, oncologist, and physician scientist at the Malignant Hematology Program in Tampa General Hospital Cancer Institute. Next, we have Dr. Lisa Nodzon, is an advanced practice registered nurse in the Department of Malignant Hematology at Moffitt Cancer Center. We also have Lindsey Nyenbrink, who is a licensed clinical social worker and certified oncology social worker at Cleveland Clinic, Florida. And lastly, we have Dr. Michael Diaz, President and Managing Physician at Florida Cancer Specialist and Director of the Patient Advocacy for the Florida Society of Clinical Oncology. Thank you, speakers, for offering your time and knowledge with us here today. Okay, so we will now begin our presentation. I'll provide today's first discussion and provide an in-depth overview on CLL, the disease, from an academic specialist perspective. Again, thank you for being with us here today. My name is Hayder Saeed. I'm a lymphoma specialist at Moffitt Cancer Center. I will be discussing a little bit about chronic lymphocytic leukemia, or CLL. I will be discussing the disease process, some of the typical presentations that you see the patients with. I will be also discussing the staging system for CLL. How do we stage it? And then some of the characteristic of the disease, some of the genetic abnormalities we look at. And lastly, I will go over some of the indications for therapy of CLL. And then I will hand it over to Dr. Kerr later. First of all, CLL is chronic lymphocytic leukemia. It goes also by the name small lymphocytic lymphoma. It's not, both of those are synonymous to each other. So that's why we call it CLL or SLL for short. While the name implies that it's a leukemia, it's really, we look at it as more of a lymphoma. According to the World Health Organization, it counts as a type of mature B-cell lymphoma. When I, in general, describe lymphoma to my patients, there are around 60 types of lymphomas. The most common types that most people heard of are Hodgkin's and non-Hodgkin's lymphoma. So CLL or SLL counts as a type of non-Hodgkin's lymphoma. When we look at non-Hodgkin's lymphomas, they're in general divided according to the type of malignant cell into the most common subtypes B-cell and T-cell non-Hodgkin's lymphoma. So SLL counts as a type of B-cell non-Hodgkin's lymphoma. The type and nature of this disease showed us that it also considered a low-grade B-cell non-Hodgkin's lymphoma. So basically, it grows very slowly with time, most of the times, on most presentations. In general, most patients with CLL or SLL will present as asymptomatic presentation. Most patients will have some abnormal labs on their blood count checks done by their primary care or by any other providers taking care of them. They would incidentally find an increase in their total white blood cell count. When this further reviewed, most of the time they found that a subtype of those white blood cells called lymphocytes is increased. And that will, in general, lead to further workup by the primary care or referral to a blood doctor who will do the testing. Most of the time, the testing can be done on the peripheral blood by blood draw that can confirm the diagnosis of CLL or SLL. Some of the other tests that can be done during the early diagnostic phase of CLL or SLL, including CT scan or CAT scan, that basically will show the extent of the lymph node enlargement in the neck, chest, abdomen, and pelvis. Sometimes PET scan is indicated and done. PET scan is a form of CAT scan that uses different type of contrast that will show the activity in the lymph nodes. Sometimes a bone marrow biopsy is needed for this testing, and other genetic testing can be done too. Other presentations for patients with CLL and SLL include incidental enlargement of lymph nodes that can be felt by the patient that does not go away. It's not infrequent that I get patients who had, for example, recently COVID-19 vaccine led to enlargement of their lymph nodes, and then subsequently had the lymph nodes never go away. That will point out those patients to the abnormal size of the lymph node and have the further testing. Other presentation could include fever of persistent fever, some night sweats that don't go away that would lead to further evaluation by primary care and further testing that would confirm the CLL or SLL. There are different staging systems that we use for CLL or SLL. The most common one is called RAI staging system, RAI, that basically represent the extent of the disease in the body. That you look at how high the white cell count that looks at the size of the lymph nodes, also on the size of the liver and spleen. And lastly, this staging system will look whether the patient has anemia or low hemoglobin or have low platelets. Platelets are the cells that basically help the blood stick together during bleeding. Some of the genetic markers we look at during the evaluation of CLL, such as TP53, you might hear your doctor talk about that test, which is a test that will show us whether the CLL will respond to certain types of therapy. Other tests, something called IGHV mutation, and also 11q and 13q testing. All of those are chromosomes in the human body, and some alterations in those chromosomes could mean whether the patient will have certain response to certain treatments. Most patients with CLL or SLL, on the presentation, they will not require therapy, and their disease will be found incidentally. A lot of those patients will not also require treatment for a while and will be followed by their doctor on what we call observation until there is an indication for their therapy. When it comes to the indication for therapy and what type of initial therapies that could be used for CLL and SLL, I'll let Dr. Alan Kerr discuss this with you on his presentation. Now we move forward to Dr. Alan Kerr. Dr. Kerr?
Okay, can everyone hear me?
Yes.
Okay. So I have some slides here, but I realize they're a bit technical, so I'm just kind of skip around a little bit, just to kind of go through an overview of our therapeutic options for CLL. Really going to focus on what we call first-line treatments. So for someone who has CLL that has more advanced disease, that's developing some of the symptoms that Dr. Hayder was talking about, that we could how do we start treatment for those patients? What are the first options? I'm also going to talk a little bit about how we manage patients who have already progressed after one line of treatment. So you had one medication and then your disease did not respond, or you did not tolerate that treatment. So really, a lot of this is technical, so I'm not going to spend too much time on it. I think there's two main things that we're looking at when we look at CLL. So one thing is that P53 mutation that Dr. Saeed was mentioned, and also there's something called IGHV. Those are two main things that we look at as oncologists to really decide what's the first treatment we should pick, and also how likely you are responding, your disease is to respond to certain treatments. I'm going to focus on two main targets that I really think have changed the game for CLL, really moving us away from chemotherapy, which used to be the standard. And those two targets are BTK and BCL2. And then again, we'll talk a little bit about relapse refractory disease. So when you have someone who has active disease and then meeting criteria for treatment, really the first decision that we look at, the first criteria is, do they have something called a P53 mutation? So if you have that mutation, that is usually correlated with more aggressive disease. However, a lot of our newer targeted therapies really still work very well, even if you have more aggressive disease. So if you don't have that mutation, a little less aggressive disease, then we look at how old you are. So if someone is over 65 years old, or they have a lot of medical problems, heart disease, lung disease, or they're very, otherwise weak, and we don't think they can tolerate aggressive therapy, then you're looking at this box kind of right here in the middle, where we have these options for targeted therapy. If someone is young and fit, and they don't have that P53 mutation, We still use these similar options, but for some patients, we are still considering chemotherapy with immune therapy, an antibody against a marker called CD20. Now, this used to be the standard of care, giving the chemotherapy with the immune therapy, but with these newer agents targeting those two molecules I talked about, we're really kind of moving away from using this in the majority of our patients. So BTK inhibitors, it's a protein inside the cell that really drives the CLL's growth and survival, right? So targeting this protein can help kind of shut down the growth of those cells. And that's really, this has been a huge breakthrough in treating CLL, and it really has changed outcomes for a lot of our patients. We're able to avoid chemotherapy, we're able to control disease for a much longer time, and people are in general doing pretty well with fairly low side effect profile. So looking at BTK inhibitors, there are a number of different drugs out there. There are 3 currently that are considered standard per our guidelines. The older one is ibrutinib, and a lot of people watching this might have already, either if you're a patient who has CLL, you might have already had this medication, or you might have heard of it. It has been around for a while. It's kind of the first generation that was used against this molecule, and it's can cause a bit more side effects. I think the biggest thing we worry about, and Dr. Nodzon will go a bit more into managing side effects and toxicities from these medications, but the biggest thing we worry about what we call cardiovascular toxicity, so bleeding, heart arrhythmias, hypertension, other things that can happen with this medication. The newer ones, if you look at the one on the right, acalabrutinib, and this one on the bottom, which is one of the even newer ones, zanubrutinib, these are newer generation drugs, and they actually have lower toxicity profiles when it comes to cardiovascular, so less bleeding events, less arrhythmias. However, they are twice a day drugs, so that BID stands for twice a day. So it is harder to take a pill twice a day. It's harder to always remember that second dose. So certainly that can be an issue. This drug at the top right also for people who are on medications for reflux called PPIs, such as omeprazole or pantoprazole, then it can't interact with that drug. So we do run into issues there. This newer drug at the bottom really does not interact with those. So if you have reflux and you're on a medication for stomach acid, you don't have to worry about that. The data here looks pretty good. It's a pretty powerful drug, although it is twice a day dosing. So that's something that we certainly have to be considerate of. So for some patients, we consider adding what we call a monoclonal antibody to this drug. So these antibodies actually bind to a marker on the surface of the cancer cell, the CLL cell, called CD20. When you add this drug to the pill, you actually can get a more robust response in certain settings. But I do think it's important to note that the toxicities can go up a little bit. So it's really a discussion to have with your oncologist as far as how aggressive is your disease, how aggressive do you need to be with the treatment, and what type of treatment can you tolerate. And keep in mind, in general, these drugs are fairly well tolerated. Usually the tolerance is better than standard chemotherapy, although there are some toxicities. I think when you add this antibody therapy to the pill, you can drop your blood counts. So when we see something called neutropenia, that is one of your types of white blood cells that helps fight infections. So that can go lower with this treatment, which does increase your risk for certain infections. The timing of therapy, we usually add that antibody on after you've already been taking the pill for about a month, but that does not always happen. I think it's important to note, and we'll be talking a little bit more about this later, that sometimes it can be a delay to getting these specialty drugs, these pills, to the patient. Financial assistance or getting authorization from insurance can take time. So a lot of times you can actually start someone on an infusion or something that we give inside our clinic before you actually get the pill, so that the standard order doesn't always occur in practice. So for people who are older or a lot of medical problems, sometimes we just give one drug, we give the pill by itself, or we might just give that antibody infusion. And I have given this to some of my patients where I just give them an infusion without any pill, because there's either they can't tolerate the pill or there's a big delay in getting that medication to them, which sometimes happens in the community. So the biggest concern we have with these BTK inhibitors is that the standard is that we start someone on a medication and we continue it lifelong. But that paradigm might be changing. We are doing additional testing, something called MRD, which is a very sensitive test to look for any residual cancer cells. And if we can achieve negativity, meaning we've knocked your cancer out completely, sometimes we can stop treatment. And I've actually stopped some treatment on patients and watched them over time, watched them very closely. And there's always that risk if you have active disease that it can come back. But if you've knocked the disease down completely, then some patients can stop treatment for a long time and still do well. So a newer therapy, and I know this is kind of a busy slide, but a newer therapy is a target called BCL2, and their new drug's called venetoclax. Now, this drug has actually been very, very effective, and the way it works is your cancer cells have developed a way to avoid being shut down or being destroyed. So this molecule actually allows the cancer cell, kind of blocks that so the cancer cell can destroy itself, which is what we want. It certainly is very effective. The one benefit with this drug is that it is a fixed duration. So the treatment is either 1 year for standard, if you have first line, what we call, first treatment, or if you've had refractory disease, meaning this is your second or third treatment, then you would do it typically for 2 years. But it is a fixed duration. So patients who are worried about taking a pill for the rest of their life, this is certainly moving away from that. Now, there is a lot you have to do with this medication, which Dr. Nodzon will talk about, something called tumor lysis syndrome, or TLS. So we have to start at a low dose and ramp it up. But usually we can get people through that as long as patients stay hydrated. We monitor the labs very closely. So it does take a little bit more work to take this medication, but it can be very effective. Also, the cardiac risk, so those arrhythmias or cardiac complications are lower with this medication. But we do have to monitor your kidney function very closely. So do we still use chemotherapy? I think there certainly is a role. I've seen patients in the hospital, for example, with very advanced disease, and we needed to get them started on treatment right away, just to keep their disease under control. So certainly we have given chemotherapy in that setting. If we have issues, taking the medication, can't, either it's hard for you to get to the medication or it's hard to remember to take it, that can be an issue. And sometimes chemotherapy can bypass that, although I typically will work a lot with my patients to try and help them set reminders and things to remember to take their medications. There are sometimes barriers to getting these medications. And again, we're going to talk more about that later. In some cases, if we have someone with an aggressive disease and there's going to be a long delay in getting them these specialty drugs, we sometimes have to use a chemotherapy-based approach just to get things under control, although we typically try to avoid that. And again, what we're saying here, this IGHV, if you have a mutation there and you're very young, fit patient, sometimes we do give chemotherapy in those settings. Now, relapse disease, really, this is a busy slide. There's a lot going on here, but really what we need to focus on is it depends mostly on what you had as your first treatment. So if you took ibrutinib, for example, and then your disease progressed on that, we would want to look at either changing the type of therapy you get, so maybe the venetoclax, or targeting a different molecule in the cell. Or if you had a treatment before, but you responded very well, it controlled your disease, however, you had to stop it due to side effects, we don't necessarily have to change the type of medication, but maybe go to a different one in the same family that you might tolerate better. So a lot of that has to do with what treatment you had previously. There are a little bit of data for other types of molecules, something called PI3K. Those drugs aren't really as effective as targeting the BTK or the BCL2, but there is some role for using those drugs if you've already tried the other ones and either your disease did not respond to it or you couldn't tolerate it. So really, if you have disease that has relapsed, a lot of times we're trying to find clinical trials for patients, which I do think is important to always discuss. I've worked at both tertiary centers and in the community, so I realize out in the community is very tough sometimes to get people to find clinical trials, but we always are looking for something that is nearby. Here, I'm near Moffitt Cancer Center, so I know that I can certainly contact the team there if there is an eligible trial. But if you're not eligible for clinical trial, we have a number of options. And again, the targeted therapies are really moving away from chemotherapy. I typically would not recommend chemotherapy for someone who has had relapse disease. So if you already had treatment, it controlled your disease for a while, then it came back. Typically do not give chemotherapy in this setting. And the reason is that these newer treatments work much better. So targeting that BCL2 or that BTK, these other mutations or these other proteins in the cell, the data there looks much better than chemotherapy. So I typically try to avoid that. Other options as far as, for very high risk fit patients, sometimes we do consider a stem cell transplant, although this is certainly not very common, especially in the setting of all of these newer drugs that are coming out. So one of the things that we're looking at for future of CLL treatment is, can we combine a lot of these agents? So for example, these two targets, this BCL2 and the BTK, targeting both independently does work well, but if you target them both together, you actually get very robust responses. And it's important to note that these trials that I've mentioned here are actually fixed duration. So you're really able to give someone a finite course of treatment, get the disease under control, and then stop treatment and give someone time away from therapy. So a therapy holiday. And we're seeing a lot more of that as we combine these medications together. So I think that that's going to be very interesting to see where these studies go in the next couple of years as this data starts to accrue. What I personally like to do with my patients, if I'm going to start a therapy, I will really see how fit someone is and see how aggressive the disease is. If the disease is quite aggressive, then I will usually do combination therapy. So I will give an antibody with either one of the pills, the BTK or the venetoclax, the BCL2 inhibitor. I usually do them both together if I have more aggressive disease. And if I get someone to a very good place where their disease is controlled and they're on a continuous medication, but they're not tolerating it, I've certainly stopped and monitored people very closely without starting a new drug. But I do think it's very important to really watch your blood work closely anytime you stop a treatment. For someone whose disease has relapsed, I'm usually going to try to target the other molecules. So if they had a BTK inhibitor and their disease was controlled, but then it progressed after that treatment, I might switch to the BCL2 or vice versa. So we want to try and target different approaches. And again, I'm trying to avoid using chemotherapy for most of my patients, really in the setting of a hospitalized patient, someone who really is sick, where we can't wait to get the drugs to them, we need to start treatment right away, then we might use it in that setting. But I do think the toxicity of chemotherapy, especially with the fact that it doesn't really work as well in most settings compared to these newer drugs, then I typically don't prefer that except for some of those extenuating circumstances. And it looks like we do have some questions. Yes, so someone said, is Imbruvica in the family of drugs? Imbruvica, yes. Imbruvica is ibrutinib. So the ibrutinib is the generic. That is the BTK inhibitor. And a couple of more questions. Yes, it looks like we've already answered those. So yes, your dead CLL has been controlled with Imbruvica. So really, I mean, he's 88 and doing well on Imbruvica. If he's tolerating the treatment and his disease has been well controlled, I would certainly continue. Now, in the clinical trials, they do have older patients on this drug and other drugs. So I think if he's doing very well on Imbruvica, I would continue that. If he can't tolerate it for whichever issue, whatever side effect he's having, one of those other two drugs, that acalabrutinib or zanubrutinib, both of those would be very good options for him if he ran into any side effects. So someone is asking about allopurinol when starting Calquence. So it really, typically, I don't always start allopurinol when starting Calquence, although if someone has what we call bulky disease or very advanced disease, your white blood cell count is very high. If we're concerned about tumor lysis syndrome, then I might start someone on allopurinol. That's not as common with the Calquence as it is going to be with the venetoclax, and that's just the nature of how that drug works. So that tumor lysis is going to be more common with the venetoclax, although we typically can manage that quite well. So yes, I don't always start it when someone is starting Calquence, although it would depend. If you had very advanced disease and I was concerned about tumor lysis, then it wouldn't be certainly not a bad idea to start someone on allopurinol. Sure. All right, so I'm going to stop here and then we can move on to Dr. Nodzon.
Thank you, Dr. Kerr. I'll now turn it over to Dr. Nodzon, who will discuss understanding treatment toxicity and management. And I want to remind everyone, keep those questions coming. We will try, if we don't have during the time during the discussion, then we will wait towards the end. We have a question and answer session, and we can answer any additional questions, keep them in the quote. Thank you.
Okay, great. So now that we've kind of gone through what is CLL, and then Dr. Kerr had kind of moved through some of our current CLL treatment options, next we'll kind of bridge things together and we'll look into what are some of the treatment-related toxicities that we see and how do we manage them. And so one of the most important things I think to point out is that, you know, most of you patients are in watchful observation, and we recognize that along that way, a lot of anxiety comes along with that. So I think the most important piece that we can do from a standpoint when patients are in watchful observation is a lot of patient education as to what are the IWCLL criteria for therapy. And that's a really important piece, because as of today, we still don't have data to tell us that your overall survival would be benefited if we treated you today versus when you actually needed it. And one of the most important concepts I think that we try to convey to patients is that once we open up the door to therapy, we can change things. One, we expose you to the toxicities of therapy, but also we can change the biology of the disease. And so until therapy is actually indicated, the way I try to put it to patients is until we need to fix something, we really don't need to do so. So a lot of the education that we do on our behalf is through teaching IWCLL. I saw a question come through there, and I'm going to throw it right back because a lot of the questions we get is, well, how high is a white count? Is there a magic number? There is no magic number. Your white count can be 450,000, like we have a gentleman, and he runs marathons. He feels fantastic. And then we have patients with white counts of 20,000 and they're already anemic. So there is no magic white blood cell number that's going to tell you when you actually meet that criteria. So that's why you'll hear Dr. Pania and I say to you a lot of times, we don't care what your white blood cell count is. We're looking for the anemia. We're looking for thrombocytopenia or bulky disease or splenomegaly. We're looking for things that we have to fix. Okay, so once that criteria is met, we also have to recognize with the median age of diagnosis for CLL patients, it's around 65 to 70. So we recognize that patients can come into this disease already with a significant number of comorbid conditions. So things that we have to consider when choosing treatment options are, does the patient have a history perhaps of bleeding? Is there a history of anticoagulant use, or are you taking blood thinners? Because that can play into what we consider for therapy. How about a cardiac history? Do you have a history of hypertension? Is it controlled? Do you have a history of arrhythmias, such as atrial fibrillation? Is that controlled? How about kidney impairment, diabetes? Sometimes we have to utilize steroids in some of our treatments. And so if you have uncontrolled diabetes, as we know, steroids can worsen that condition. How about GI issues? Do you have irritable bowel syndrome? Do you have chronic diarrhea, ulcerative colitis? Lung function is also important for us as well. COPD, do you get lots of pulmonary infections? So those are important. Other patients can come into CLL with arthritic conditions, so myalgias and arthralgias. So some of the agents that we treat with can also exacerbate that condition. Other considerations, obesity, as well as sedentary lifestyle. So patients can come into this disease already with feeling fatigued and being very sedentary with unhealthy diets, as well as having a depression or even mood disorders. And this can be exacerbated now by this diagnosis and then the indication that that therapy is needed. And as Dr. Kerr had pointed out, that we have lots of new therapies that have really hit the market. Back in the day, chemotherapy was the mainstay. But now with these new oral targeted agents, we can really overcome some of these adverse prognostic markers, such as IGVH unmutated, deletion 17p and TP53, still considered higher risk. But these newer oral agents are much more efficacious than chemoimmunotherapy was. So that's why, as he pointed out, you rarely see us utilize it nowadays, and really a small niche of patients that it's really suitable for. But with these newer targeted agents, they also will impart their own AEs on the patient. So with the BTK inhibitors, we have those that fall in that class, acalabrutinib and ibrutinib, and then the newest comer to the market is zanubrutinib, and pirtobrutinib will be coming out soon enough. The only BCL2 inhibitor we have is currently on the market is venetoclax, and Dr. Kerr touched on that a little bit. It's the only drug on the market that carries MRD data with it. So the beauty with venetoclax is that it does offer you the opportunity for time-limited therapy if you're a candidate for that, versus the BTK inhibitors. We know the clinical benefit is really derived from long-term therapy on those drugs. So we tend to tell patients, once you start a BTK inhibitor, you're going to be on that therapy indefinitely. We know these agents can be combined with or without, as he mentioned, one of the anti-CD20 monoclonal antibodies, obinutuzumab or rituximab. Some of you patients may have received ofatumumab back in the day. So we can be treated with a doublet. Clinical trials are also looking at triplets. We kind of joke around with our myeloma friends that we have to have triplets too, just like you guys do, or even clinical trials. You know, we're putting some of these agents together for the synergistic effect for the pathways. But most importantly, you'll see us when we do start on therapy. A lot of times we do recommend seeing a cardio-oncologist for the BTK inhibitors. And why is that? We find it really important for the multidisciplinary approach. We know the BTK inhibitors as a drug class in general, the proportion of patients, 10 to 12% or so, can develop cardiac arrhythmias. So we want to make sure that things are fine-tuned before you start out on therapy, meaning, do you really need to be on that aspirin, because we can increase the propensity for bleeding risk, because BTK inhibitors can interfere with platelet aggregation. So they're a bit sluggish to the scene, if you will. And so we like you to be seen to, one, why are you on aspirin? Was it appropriate to be placed on aspirin, or did you put yourself on aspirin? Are you really a stroke risk? How about the risk for atrial fibrillation? Is that in your history? Are the antihypertensives that you're currently taking controlling your blood pressure? Uncontrolled hypertension can lead to atrial fibrillation. So we want to fine tune things from the get-go. You'll also see a lot of our nurses are involved in your care after you start one of those oral agents, calling you on the phone, making sure you're tolerating drugs, as well as the specialty pharmacist as well. You'll hear a little bit tonight with regards to the financial counselor piece. These drugs are incredibly expensive. We recognize there's financial toxicities. It's not just the drug, it's the frequency of visits, it's the labs. What other medications are we having to prescribe as well to support you on as well? But regardless of the therapy option that you're placed on, I think one of the biggest things that we see in our patient population recognizing is that you guys can come into CLL with what we call hypogammaglobulinemia. So immunoglobulin levels are low, so you could be more prone to infectious complications. So you'll see us get pretty aggressive, at least at our clinical practice, with monitoring out for IgG levels and giving IVIG immunoglobulin support where appropriate, particularly if you've got a history of bacterial infections and you're getting the antibiotics pretty frequently. A lot of times patients will ask, well, how bad is my immune system? Well, that depends. How often do you get infections? We have patients that never get infections. And then we have some patients that have a lot of sinusitis as well as pneumonias, and they're admitted for that. So it really just depends on how is your history. But if you're low enough, we can offer immunoglobulin support. So you'll see us get pretty aggressive with monitoring of that and then titrating around you guys. But if we look at those drugs individually and what they can impart to you, each drug really has what we call its specific menu of poison, if you will, for what the drug's going to bring to you, and then what does your comorbid condition. So when they meet each other in the middle, what can happen? So as I mentioned earlier with BTK inhibitors, we know that your clinical responses improve over time. So really the benefit of these drugs, ibrutinib, acalabrutinib, zanubrutinib, your benefit is going to be derived over time. So that's why when you start, we say to you, your therapy is going to be indefinite for you because your response will get better in time. But we also recognize that with indefinite therapy comes the financial toxicity. And here can come chronic toxicity. So we'll see you pretty frequently in the beginning. What we're really after is how are you tolerating the drug? Sometimes you'll see us titrate your dose up from small to large, depending upon comorbid conditions, what we think we might exacerbate. You'll also see us do referrals to cardio-oncology. We're very fortunate to have Dr. Alamar at Moffitt Cancer Center, but also we're going to fine tune other things. Are you on aspirin? We're going to educate about bleeding. We know that being on ibrutinib is similar to, for lack of a better term, like being on a blood thinner. You might notice easier bruising, easier bleeding. So it's important to avoid other agents that can also lead to bleeding. Vitamin E, aspirin containing products as well, taking a lot of ibuprofen if you've got joint aches and pains, other things. So we'll educate you on that. One of the other things that's really important to understand also, because really you're your own best advocate, is when you're going for surgery, the need to hold ibrutinib in that perioperative period, or acalabrutinib or zanubrutinib, because these drugs can have that effect on platelet aggregation or the ability for platelets to clump. So best recommendation is to always contact your clinical provider and say, hey, I'm having a dental extraction, because we might recommend holding it for a couple of days. Or are you having a hip replacement? We might recommend holding it for longer, because when you go for your surgical clearance, these drugs are not going to be listed on that surgical clearance form. But the question will be, are you taking blood thinners? But this drug will not be there. And most outside providers are not aware of that. So the other one that's often overlooked as well is the colonoscopy. We always recommend holding it before a colonoscopy. They're going to take the polyps when they see them. They're not going to go back. So recommendation is to hold before the colonoscopy as well. The other thing with the BTK inhibitors is hypertension. We tend to think that most side effects occur early on in therapy, but that's not really the case. With the real world data that we see with hypertension, we typically see this arising at the end of year 1, maybe the end of year 2. And some studies are even showing up to 78% of patients by 30 months. And this can be in patients where they've never experienced hypertension before. So we might begin to ask you to maintain a blood pressure diary, recognizing that these drugs can do that to you, this particular class, and then maybe following back up with the cardio-oncologist or the primary care. Uncontrolled hypertension can obviously have consequences on the kidneys. It can lead to atrial fibrillation. It can lead to bleeding. So we want to make sure that we get that nice and tightly controlled. Arthralgias, an early side effect we tend to see with the BTK inhibitors as well. Joint aches and pains, if you've got underlying arthritic conditions, this might be exacerbated. So we might need to play with some dosing. We also might need to play with some other medications to help you out in the beginning as well if you're experiencing this. Atrial fibrillation, as I mentioned earlier, varying degrees depending upon which of the BTK inhibitors that you're taking, but atrial fibrillation can occur. Not a contraindication if you have AFib to still be on one of these agents, but with AFib, you're also going to be placed on a blood thinner. So now it's going to increase that risk for bleeding because here's the blood thinner in combination with the BTK inhibitors. So we'll have you follow up pretty closely with the cardio-oncologist just to see how are they going to manage that atrial fibrillation. Did you go back into normal rhythm, or is further testing going to be warranted? So something of consideration. With acalabrutinib, something that's rather unique is headaches. They tend to occur early on at the start of therapy. Most patients don't notice the morning headache. Why? Because you're having a caffeinated beverage, and we learned pretty early on in the trial that caffeine was a nice remedy for these headaches, but then there's the evening. So we might have to play with the timing of your dosing when it comes to acalabrutinib, but they tend to be transient, meaning they tend to occur early on and then improve in time. But we have other remedies if those headaches are still persisting, but caffeine was one way to remedy that. As Dr. Kerr had mentioned as well, these anti-CD20s that we give, these IV infusions, rituximab, obinutuzumab, et cetera. These drugs might also be given in combination with these BTK inhibitors. And particularly, we give obinutuzumab with venetoclax. But it's really important to point out that when you get these medications and we talk to you about pre-hydrating, the need for allopurinol. The reason for this is because we recognize that phenomenon that he mentioned called tumor lysis syndrome. So, you're giving you a foreign protein, your immune system is designed to do what it's designed to do. It's going to react. Here comes an infusion-related reaction. Some of you might be familiar with where you can feel sweaty. You might feel like you're going to lose your bowels. You might feel like you're going to pass out. You could have issues with your blood pressure. So we'll ask you to hold your blood pressure medications on the day of those infusions. You can bring them with you, but we'll ask you to hold blood pressure meds, come hydrated. We'll also place you on allopurinol. The mechanism of action for these particular agents is direct cell kill. So these cells are going to lyse open when they're infused to you. We're also going to place you on an antiviral, acyclovir, usually is the one of choice prophylactically. If you've ever had chickenpox in your history, you run the risk of reactivation for shingles. We see a lot of shingles in our CLL population just from the immunosuppression that you guys endure. So we'll place you on an antiviral just to hopefully prophylax you against that. But you can also have reactivation of other viruses as well, because we're depleting the B cell population. Vaccines, I know COVID has been a hot topic. You'll hear lots of us, even before COVID, talk about the fact that in the setting of receiving one of these anti-CD20 monoclonal antibodies, it's not new data, rather the rheumatologists have known it for decades, that when patients are receiving one of these agents and they go to receive a vaccine, the vaccine may not take it all. So obviously that posed a lot of questions and issues with the COVID vaccines for our patients. So the recommendation is if you can get the vaccine, get it before therapy starts, because you might not have a response. And it typically takes 6 months to 12 months after that last infusion before you'll have a serologic response to a vaccine. So keep that one in mind. We don't want to delay therapy for that reason alone, but a lot of you have questions with the COVID vaccine and what's going to happen. We don't give extra vaccine. It's just that the B cell population can be depleted. The other agent that was talked about was venetoclax. That's given in combination with obinutuzumab, or it may be given with rituximab, or it may be given single agent. In the front line, typically you'll receive that obinutuzumab first. So we don't see too much tumor lysis with venetoclax because you've been already debulked with the obinutuzumab, at least in our clinical practice. So by the time venetoclax rolls around and you're on that 5-week ramp up, the allopurinol is starting to dwindle away when we pull it away from you. But one of the big things that we see on venetoclax in our patients, maybe up to 60% of them, is this neutropenia. And many of you are probably familiar with the utilization of growth factor, where your neutrophils are falling below 1,000. And so we'll talk to you about self-injection or getting injections at our center. So we want to keep those neutrophils up. Predominantly, you tend to see more of that when you're receiving the infusion in combination with venetoclax. But that's really the biggest thing that we're after when we receive venetoclax. We tend not to see all the bleeding issues, the cardiac issues, things like that, but neutropenia is a big one. And so monitoring out for infection is really important with that. Dr. Kerr touched a little bit on the PI3K inhibitors, duvelisib and idelalisib. We tend not to see them utilized too much in clinical practice. There's a niche and there's a need for them as well. They do target a different pathway in our patients. But right, they haven't been shown to be as efficacious, if you will, to the BTK inhibitors as well as the BCL2 inhibitors. But they do carry their own risks as well. Typically in the front line, we tend to see more of what we call the itises, pneumonitis, colitis, CMV reactivations, things like that, as compared into the relapsed or refractory setting. But they might have their place for patients that maybe are intolerant or patients that is a bridge to something else. So they might have their place, but you may or may not be on them. But important, when you're on them, you're going to see us give you a prophylaxis, typically with a Bactrim. Why? Because we're trying to prophylax you against a certain type of pneumonia that you can get that's opportunistic, as well as we'll be checking you for what we call CMV reactivation that can come inherent with these agents. The other big thing to be on the lookout for, and I think this is really just going to be true across the oral oncolytic world in general, is that most of you recognize that these drugs come from specialty pharmacies. If not the specialty pharmacy, they're coming from the dispensary that perhaps where your drug is coming for financial assistance, it's important to keep in mind that that specialty pharmacy or the drug that's dispensing, if it's through financial assistance, is not having any crosstalk with your local pharmacy. So one of the big important things we have to consider is these drug-to-drug interactions. There's no crosstalk, and we recognize the patient is in the middle. So one of the recommendations is for you to always keep an accurate medication list with whatever pharmacy you're utilizing. If you're utilizing your local Walgreens or CVS, please let them know that you're on one of these agents, because when another provider goes to send you just a drug that may be needed, it could be a drug for cardiac, could be an antibiotic, that drug may interact with your drug that you're on for CLL therapy, and no one's going to have any way of knowing. The other thing that you can do too, that we also advise, is to contact whoever's dispensing that specialty drug and say, hey, Dr. So-and-so wants to prescribe this. Is there an interaction with whatever drug that you're on, because a lot of those drugs do have interactions. Typically it's the cardiac medications. A couple of antibiotics also make the list as well, and a few of the antifungal drugs. But really that just represents more of like a patient safety issue as well. And so that's why every time you come in, we'll ask you about having an accurate med rec. But I think most importantly is just keeping the med rec accurate with whatever dispensing pharmacy you're using, and just making sure, because at the end, it's the pharmacist that's really going to catch those drug-to-drug interactions. So I will conclude with that. Sorry, those of you that know me know I like to talk a lot, and I really try not to go over time. Sorry.
And you love to talk about CLL. That's your favorite subject.
I know, I don't know who's worse, me or Dr. Pinilla, with him.
Well, thank you for sharing, Dr. Nodzon. We will now move on to the topic of patient assistance programs and caring for the caregiver, and welcome Lindsey Nyenbrink to highlight those important resources. Lindsey, I don't think we can hear you. I think you're on the mute.
Okay, can you hear me now?
Yes.
Okay, I'm just working on sharing my screen. Can you see my screen?
Yes.
Okay, I'm so sorry.
It's at the.
Here we go.
Right.
Good?
Great.
But you can see all this now. Okay, so my name is Lindsey Nyenbrink. I am a licensed clinical social worker and an oncology certified social worker. I'm going to be discussing support services for patients. I want to spend more time discussing caring for the caregiver, and then also some financial assistance programs. Okay, so for patients, while patients are being treated medically, most cancer centers are now focusing on multidisciplinary approaches, because it's so important that we focus on psychosocial support for the patients to support them emotionally as well. Most major cancer centers have social workers accessible to the patients, who will typically screen patients at pivotal visits, whether it be the initial medical oncology visit or any other visit we try to catch you. But if you haven't heard from your social worker, I'm going to encourage you to ask to speak to a social worker, whether you feel that you need them or not, because they can really help you throughout your cancer journey. And again, it can be in the beginning of your cancer journey, during treatment, or when you're done with treatment. So each cancer center should have a social worker, and they can provide resources for patients who may need individual support. They can link them up with therapists. There's group support and peer support as well. A lot of major cancer centers have these resources within their own cancer center. So the social worker can get you linked up with those resources at the cancer center. If they felt that you needed further support, they are well-versed in the community resources that would be appropriate for you, and then they can direct you towards the appropriate one in the community. You can also utilize your social worker if you were to ever need any medical equipment, home health care, and then any other type of referral. So they're just a great resource to have. Again, if you haven't linked up with your social worker, ask to speak to one, or to have their number, just so when you're ready, you have it. So I just really wanted to briefly touch on that and go into a caregiver. So who is a caregiver? A caregiver is anyone who provides different types of support. It can be emotional support, which can vary. It can be near or far. Somebody can provide emotional support to a patient over the phone. A relative who lives in another state, just because they're not geographically near to you doesn't mean they're not caring for you. They could be calling you to check in with you. It could be somebody that you vent to, cry to. So that's emotional support that caregiver provides to you. Caregivers provide physical support. They become the person to help bathe, cook for you, clean your house, clean you, provide transportation. They're your spiritual support through faith, however, that is to you. And then financially, a lot of times when somebody is diagnosed with cancer, unfortunately, it could be the main breadwinner and they can no longer work. So the other caregiver now has to step up and become, the other person in the family has to step up and become the caregiver who provides the financial support, and they're the only income coming into the family. So statistically, the caregiver tends to fall on the child, sadly, and it's not always an adult child. A lot of times it's a teenager. Second to that, the caregiver typically falls to the spouse, but a caregiver, again, is anyone who provides any of these types of things. And it can be a father, a mother, a husband, a wife. It can even be a friend or a coworker. Anybody who is providing these different things for you is considered a caregiver. So it's very common for caregivers to feel high levels of psychological distress due to the sudden life changes in their new roles. Now, when a patient gets diagnosed with cancer, of course, it was not expected. It throws a whole world upside down for the patient. But many don't realize that for the caregiver, it does the same to them as well. They're now in all these different roles that they weren't in before. They have to become the nurse for the patient. They're providing the medication. They're making sure they're taking the medication. They maybe are the housekeepers, whoever got diagnosed, maybe that was their role. And so now the husband has to do all the chores, or the children have to do all the chores. Someone who may not be used to cooking now is doing all the grocery shopping and the cooking. They become the secretary. It's a really big job to be a caregiver. You take the patient to all their appointments. You're their chauffeur. When you're at the appointment, you're taking the notes because you want to take less off the patient. So you take the notes, you fill the prescriptions. If the person who was diagnosed was the one paying the bills, now that falls on to the caregiver in the home. They have to make sure that the bills are paid. And they also become kind of like the psychologist. The caregiver is the closest one to them. So they're going to vent to them. They're going to cry to them. They're going to tell them when they're in pain. So it could be any of these roles that they take on, or it could be all of these roles. And it's all just, it really turns their world upside down as well. So what are some things that their caregiver may experience? You as a caregiver, you may feel these things. And what is it? A feeling of helplessness. So you're watching your loved one be sick, and that's really hard, especially because there's nothing you can do about it other than provide the support. You have to watch your loved one be sick, be in pain, and you have no control over it. So the feelings a caregiver may experience is the feeling of helplessness because they can't do anything to, make them better in that moment. Caregiver may feel isolated. Everyone around them is going on with their lives. Nobody else's lives changed, but theirs. So it changed instantly for them. So now they spend a lot of their time at home. They're not able to do their normal activities that they enjoyed. Some caregivers may not even be able to work. A lot of my patients' significant others, who will go out on FMLA. So now, because they have to take them to all their appointments and care for the patient, so they're not able to work, and sometimes work as an outlet for caregivers. So that's now taken away from them, and it's kind of leaving them with no outlet. So it's a lot of alone time, and they're not really focusing on their self-care. The caregiver takes on making decisions. If the patient is too sick, the caregiver then may take on these decisions. So it stresses them out. They now have to make decisions for themselves and for the patient. And that's something they might not want to do, but they have to do because the patient's too sick to make those decisions. Like the doctors were saying, sometimes when it's so progressed, the patient's in the hospital, and if they're unable to make decisions for themselves because they're just too tired or weak, they'll ask their significant other to do it. So having to do that is mentally overwhelming and stressful in itself. And it can be very overwhelming to have to be the cheerleader. A lot of people look to the caregiver to be the cheerleader, and you know, the patient does too, but that's a lot to ask of somebody 24/7. It's exhausting physically and mentally to have to be happy all the time, which they don't need to be. So all this can lead to caregiver burnout, which is essentially what we want to avoid. But all these things, as you can imagine, they build up, and then the caregiver gets burnout. And what does that look like? So caregiver burnout is a real thing, and it's something that, you know, the patient can look out for, clinicians can look out for, and the caregiver themselves can look out for, because you want to avoid the burnout. So you can try to catch it before it happens or as it's happening, and then give them the appropriate resources. So what do you look out for in signs of burnout in a caregiver? If they're tired all the time, so obviously a patient's going to be very tired from the treatment and everything, and the caregiver has a lot of work to do. But if they're just sleeping more than usual and they're not getting up to do their daily tasks, eating poorly, loss of appetite or overeating, overusing substances, drinking too much alcohol. And again, all these things can be different for everybody, and something may not be listed here that applies to somebody, but these are some of the main ones that you can look out for, or even ask a caregiver when you're talking to them, you know, are you sleeping more than usual? How do you sleep at night? You know, if they say that they're having trouble falling asleep or staying asleep. Losing contact with friends is a common one because they're so busy. They just don't answer the phone calls, they don't return the phone calls, and they don't take time for themselves to talk to their friends. A lot of times the caregivers don't want to give a million updates, so they kind of distance themselves from their friends, which is further isolating them. And the reason why we don't want caregiver burnout, among other things, is it can get to a point where they're so resentful, they may blame the person with cancer for the situation. And they don't really mean that, but they're just at this point where they're kind of burnt out. So we want to avoid that from happening. You know, looking for signs of the caregiver feeling anxious, depressed, sad, or hopeless, or expressing those feelings to you. And then it's very common for the caregiver to ignore their own health issues because they're so busy with the patients. They're not making time for their, you know, dental appointments, vision checkups, medical, or, and very importantly, their mental health. They're not looking out for that, and they're not focusing on that. Now, the mental health of the patient and the caregiver is very synergistic. This is why it's so important to prevent caregiver burnout. We can't expect the caregiver to be the cheerleader 24/7, but if we work with them and they have a healthy balance, then it benefits everybody, because when the caregiver feels good mentally, typically the patient will be more positive too. If the caregiver is stressed, then the patient's going to pick up on that, and they don't want to feel like a burden, and we don't want them to feel like a burden. So, you know, we don't want them to be any more stressed than they have to be. If the caregiver were to become depressed, then the patient may become depressed too, and now we have the caregiver and the patient depressed, which neither do we want. And then, of course, if the caregiver gets overwhelmed and extremely stressed, they can become sick. Now, if the caregiver is sick, who's going to help take care of the patient? So it just makes for a bad recipe. That's why it's so important to prevent the caregiver burnout. So when I meet with my patients and their caregivers, and I notice that the caregiver is kind of, you know, not paying attention to their own needs, I always tell them the story that, and I use this reference, put your oxygen mask on first. And what I mean by that is, you know, when you're on an airplane and the flight attendant gives the instructions, well, I never used to listen until I had my own children. And I remember being on the plane with my small son and listening to the instructions when we were about to take off. And the flight attendant said, you know, put your oxygen mask on first and then help the person next to you. And as a parent, I looked to my husband and I was like, that's ridiculous. What kind of mother would I be if I didn't take care of my child first? And my husband replied, you'd be a passed out mother from lack of oxygen, and then you won't be any help to our son. So caring for the caregiver is the same concept. Caregivers won't be any help to the patient without their oxygen first, without making sure that the caregiver is okay, without taking care of themselves. They won't be much of a caregiver. That's why it's so important that we take care of not only the patient, but the caregiver. We need to make sure that they practice self-care to be a better caregiver and to better help the patient. So I keep saying taking care of yourself, the caregiver. What does that look like? How? How do we take care of the caregiver? Be aware. If you notice as a caregiver or as a clinician or a friend or anyone who's listening, if you notice yourself as a caregiver that you're starting to get overwhelmed, take action. Now, what does that mean? That means delegate. And as a patient too, this is what I tell my patients: delegate tasks. This is the time in your life when people want to help you and they don't know how. So as a patient and a caregiver, tell your friends and family what they can do. Delegate the tasks. It's okay. They want to help. They just don't know how to help. So tell them, be like, oh, if you can bring me dinner, if maybe they can take you an appointment, ask a friend to help out, just to take a little bit off your plate as a caregiver. And it's okay to be direct and ask for the help, because if it helps you as a caregiver, it's helping the patient. And the friends and family want to be involved. So this is a great way for them to be involved. It's really good for the caregiver to know that they're not alone. It's very isolating, like I previously said. So as a caregiver, there's support services too for caregivers, many support services for caregivers. So ask your social worker. But there's peer support for caregivers, there's individual support, there's support groups, many that are very beneficial so that you don't feel like you're alone. It's a place you can talk to other caregivers who can understand what you're going through. I put breathe there because I know obviously we have to breathe to stay alive, but I mean, really take a second and breathe. It's so important to maybe 5 or 10 minutes of your day, do some deep breathing, and it can just really relax your body, your state of mind. And if you have to, make a list of these things. It's hard to remember all the things to do on a daily basis to help yourself. So put breathe on it, even though it sounds silly, breathe, meditate, take it one step at a time. Caregiving is a marathon. It's not a sprint. It's a long road. It's very important to pace yourself as a caregiver. Don't overfill your plate. Like I said, you can designate certain tasks to other people, but also designate certain tasks to your day so you don't overwhelm yourself. You can keep a list, like a small notebook, and designate each day what you're going to do so you don't put too much into your day, and so that you can also schedule time for yourself in the day. Take 20 or 30 minutes for yourself. That's okay. You have to do that for yourself. And I also encourage caregivers to ask to speak to a social worker. We're not just for the patients, we're for the whole family, that being the caregiver or anybody else. If you can't remember to take time for yourself, put an alarm on your phone. Put reminders, do anything that brings you enjoyment, relaxes you, or even if you can just go for a walk for 10 minutes and get fresh air, take that time for yourself. So it's also easy. I tell my patients the ABCs of caregiving: awareness, balance, and connecting. Awareness, be aware of your feelings. It's okay to cry. I tell both my patients and caregivers, if you have to cry, you can cry, and you don't have to hold it in. It's okay to cry in front of each other because you're human. Don't censor your emotions. It's okay to express how you're feeling in front of each other because you don't want it all to build up and then it comes out the wrong way. If you hold it in, it's not going to do anybody any good. Balance means know your limits. Walk away when you need to. Take a moment, take a few minutes, find a quiet place, do your breathing, whatever it is, and connect. Communicate. Very important to communicate, whether it be with the patient about how you're feeling, with a support group, and reach out to your friends. Stay connected to them. Don't pull away. Connect with your loved ones, connect with your friends, and always, always connect with your social worker because we are here to help you. And then lastly, I wanted to discuss financial resources. I probably daily get asked about financial resources, especially for CLL blood cancers. I think I skipped over it, but in the first slide, the Leukemia and Lymphoma Society, I encourage, it's on here too. I have the website right there. I encourage all my patients, even if they don't feel like they're going to need it, register with the Leukemia and Lymphoma Society. They are a great resource, financial resource, emotional support resource, and just a community resource. So you can go online and register with them. A lot of cancer centers have financial counselors specifically there to help you with co-payments. A lot of the drugs that the doctors were saying have high out-of-pocket costs. The social workers, the financial counselors can help apply you to programs to help pay for those costs so you don't have a high out-of-pocket cost after your co-payment. One of the websites that I always refer my patients to, I listed here, is the Needy Meds website. It's got foundations on there that you can apply for. You can do it yourself. Your social worker can help you. And then why it is also important to speak to your social worker about any financial needs is there's a lot of community grants that only the social worker can apply you for, that you're not allowed to apply for yourself, so you wouldn't know about them. So you have to communicate to your social worker that you need help with something so that we can apply you for those grants, find those grants for you, and get you linked up with those and the different foundations. And that's it.
All right, thank you, Lindsey, for the great discussion. We will now move on to the question and answers portion of the agenda. I kindly ask all the panelists to turn on their webcams. I think many of the questions have been answered throughout. So if you have any more questions, please go ahead and send them. I think Dr. Kerr and Lisa Nodzon answered many of the questions that has been proposed throughout the chat. While we wait for maybe some additional questions, if they come through, I came up with some of the questions that I noticed. My patients always ask about. First one maybe is a good question for Dr. Kerr. Do you have any preference based on efficacy on one of the BTK inhibitors over the other, or do they all work the same to you?
So yeah, that's a very good question. I think in the first line setting, I mean, we have the longest data for ibrutinib just because it's been around for a long time. So we certainly do have very durable responses. But the newer data for both the acalabrutinib and zanubrutinib are quite good. And I do think certainly if I have a patient who can tolerate the medication, they can take the twice daily dosing, then I would prefer using either acalabrutinib or zanubrutinib. Certainly the biggest problem I would have with acalabrutinib, I've had to do this with patients because if you have very bad reflux or peptic ulcer disease and they're on a proton pump inhibitor like omeprazole, that's a big issue. And if you cannot stop that and use a different antacid therapy, then you're going to run into problems with that medication. I really do like zanubrutinib, to be honest, because you're not running into that interaction. And you also have the lower cardiac toxicity compared to ibrutinib. So if I had to pick one, I think zanubrutinib, I do think is although the data is shorter, right, because it's a newer drug. But I do think, especially with the newer data coming out, combining that with a CD20 antibody, it's looking really good. So I really like that medication. I think the biggest issue I run into with that one or acalabrutinib is just compliance. It's hard, and I understand it too. I'm terrible taking my own medication. So, trying to take a pill twice a day, remembering that second dose is very difficult. So that is a bigger barrier than we think about a lot as physicians. But certainly if I don't run into that issue, I really do like zanubrutinib or acalabrutinib. One thing I've seen with ibrutinib, and Dr. Nodzon, she might, obviously she's been doing this a long time and a lot more experience. I've seen some pulmonary toxicities, some patients getting interstitial lung disease. It's been reported in the literature. I don't know, Lisa, if you're seeing that. I've seen just a few patients. It's probably just recall bias, but I have run into that issue and had to stop therapy because of that.
Yeah, we've just had, like you said, very rare, maybe like through case reports, had probably 2 cases of pneumonitis.
Okay.
But yeah, we had one case of it. Yeah, we had one patient that came to us like that.
Dr. Nodzon, can I ask you about venetoclax? What's your criteria, or what do you guys use for decision making, whether, for example, to admit them to the hospital or not when they start that treatment?
Yeah, so we haven't admitted anybody since the CLL 14 trial. Strategy for us, frontline, like I mentioned earlier, if the patient's going to be receiving obinutuzumab in the frontline setting, then technically they're debulked. By the time you start that Venclexta ramp up, and unlike in the trial for day 22, we start them with cycle 2 just for logistics. They're lymphopenic, if not neutropenic by then. So we haven't seen any TLS. We've seen TLS with obinutuzumab, but if it's a patient relapse refractory setting, completely off label, but if we can get away with it, we're going to also debulk them with obinutuzumab. Obinutuzumab is only approved in the front line, but if we can get it by insurance, we'll debulk them, bridge them over, if you will, with obinutuzumab, so that we can start them safely on Venclexta monotherapy. But with regard to the TLS and the both the CLL 14 and the Murano trials, they both saw 0% evidence of clinical TLS, and then even with just the biochemical TLS, it was really 1% to 2%. So I think the drug clout, a lot of patients ask us about that. I think the clout really comes from when the ramp up was over the period of maybe 2 to 3 weeks back when it was still called ABT 199. But in our hands, we haven't seen TLS, and we don't admit anybody. All of our patients as a strategy are debulked before that ramp up starts.
Can I ask you also about, you talked about COVID and COVID vaccine, and I think Dr. Kerr answered some of the questions about COVID in the chat, but any other strategies you use to protect patients? As we know, those patients who are taking BTK inhibitors might not mount a response to COVID vaccine. So do you have any strategy to protect them? Any other interventions?
Yeah, so right now, and probably similar with Dr. Kerr at Tampa General, AstraZeneca's just rolled out their Evusheld. So the majority of the patients that are contacting us now with regard to, hey, you know, I had the COVID vaccine, I received my 3 shots. I'm curious if I'm eligible for this product. And currently, so Evusheld for the patient audience tonight is a product that's given intramuscularly for patients that have not mounted a response to the antibodies. Reasons for that, as we mentioned earlier, for patients that receive could be a BTK inhibitor where we know real world data for response is incredibly low with vaccines alone, just in our CLL population, just because of the immune dysregulation. But also most importantly, in the setting of receiving one of the monoclonal antibodies, obinutuzumab, rituximab, ofatumumab, because we're depleting the cells that are now responsible for making antibodies. And we know that those drugs, they target the good and the bad. So they're targeting your CLL cells, but they're also targeting your good B cells. And so when you attempt to get a vaccine under this setting, you may not even mount any antibodies at all. And so one product that hit the market then is that AstraZeneca product, whereby if you've received one of these anti-CD20 monoclonal antibodies within the past 2 years, or currently on a BTK inhibitor, we bring you out, we test you for the S antibody, and the S antibody just tells us whether or not you have mounted an antibody response. There's no predictive threshold. The number is completely irrelevant. Either you're positive or you're negative. Whether if you have a number, it doesn't tell us that, hey, you're golden, you're going to be good, protected against COVID. It just tells us either you mounted a response or you didn't. If you did not, you're eligible to receive Evusheld. The concept behind it is that it now gives you these 2 antibodies against COVID-19 for a period of about 6 months. I think the data claims to be around efficacy, 88% or so. So that's a strategy that we're utilizing for the patients that did not mount a response. Of course, early on, we had a lot of patients contacting us that Leukemia Lymphoma Society was checking antibody titers on them. And what does it mean? What does it mean? I think it's important for patients to understand we don't know what it means. We don't know what the numbers mean. You know, if you look at the data, there's healthcare workers that came down with COVID, had the 3 shots, and then there were other people that did not come down with COVID, had the 3 shots. And when they looked at their antibody titers, they were exactly the same. So the key point is there is no predictive threshold. You either have antibodies or you don't. We just don't know how much do you need. is the key point. But if you don't have antibodies, and that's what Evusheld has been recommended for. So to get it at Moffitt, you have to have your 3 vaccines, the last one being 2 weeks out, have to have received one of the anti-CD20 monoclonals within the past 2 years, and be on a BTK inhibitor, because we're trying to prioritize the patient right now. You know, we get these drugs are still under emergency use, so we do get limited supplies from the federal government. Alan can probably talk a little bit more how they're doing it at Tampa General, but then after that, we might roll it out for the remainder of our other population.
Yes, at TGH we're also using Evusheld, and we're expanding that to certainly other cancer patients with cytoreductive chemotherapy, or chemotherapy that's immune suppressive. So we're really expanding it to a large proportion of our oncology patients, since they are all at high risk. But Dr. Knotts is exactly right that the antibody titers, as far as quantitative levels, what level is there a set cutoff, we really don't have. There's no strong clinical correlation there. Just like she was saying, you can have high titers and still get infected after vaccination. So I think we really need to focus on what population we know is going to be at risk. Just like what she was saying, based on the CLL, the disease itself, based on the treatment we're using, we know that you're going to be at higher risk. So certainly we consider that's the population that we're going after. So we are giving that to our CLL patients, as well as our other oncology patients. It seems to be fairly well tolerated. I don't know how you guys are seeing it at Moffitt. I'm not seeing a lot of reactions to the medication. It seems to be, pretty fairly well tolerated. I think the data does look good. Certainly, the 6-month data looks good. I think it's going to pan out probably a bit farther. These monoclonal antibodies certainly have a long half-life in the system. So I would certainly favor considering that. I've been telling most of my patients to consider that, just given how well they seem to be tolerated, and how high risk, especially a lot of our CLL patients on treatment, can be to the COVID infection.
Okay, so we have additional question here from the audience. It's from Jan Holmes. She asked, I recently started treatment and I'm on Calquence, acalabrutinib. Basically, I have a terrible abdominal pain and back pain due to swollen lymph nodes. How long does it usually take to have some relief to the pain after starting treatment? It's been about 6 weeks, so I'll leave it. Maybe either one, Dr. Kerr or Dr. Nodzon, to answer this question.
I can. Are you just taking the Calquence would be my first question. Did they add any other treatment? Are you getting an antibody infusion with that? Typically, Calquence response can be usually within a few weeks. Sometimes we'll see, when we start these BTK inhibitors, we'll see your white count kind of go up before it comes down. So you don't see a very rapid response, but if you've been on it for 6 weeks, in general, most patients are having some response at that time. Although I will say, when you have enlarged lymph nodes causing pain, even as those lymph nodes shrink, sometimes that pain doesn't go away as quickly as the lymph nodes shrinking, if that makes sense. So you could get a CT scan, the lymph nodes look a little bit smaller, but you still have that pain that can last a little bit longer. Sometimes those lymph nodes are pushing on other structures, sometimes pushing on certain nerves. So there can be some irritation there even after we shrink the lymph nodes. So the pain itself might last longer than the enlarged lymph nodes.
Okay. And I have one more question that I get asked all the time from my CLL patients, and I want to see what your opinion on. I get asked all the time about any special diet that can make my CLL better or worse. So what would you comment on that?
We always tell our patients, we go back to the basics. It's the food groups that we learned in elementary school, the things that we know we're supposed to eat and we know what we're not supposed to eat. One thing we do not like and we do not endorse is supplements. If any of you have ever heard Dr. Pinea's antigen presentation in clinic, because you're taking supplements, don't show up taking supplements or you're going to hear his presentation. When it comes to supplements, you and I can go out in the market tomorrow and put them on the market. They're not regulated. We have no idea what's in them. And sometimes we hear from patients, well, they're made from plants. Well, so is chemotherapy. That doesn't mean it's safe. So we don't like supplements. We're A-okay with multivitamin, your calcium, your vitamin D. Vitamin E, I mentioned earlier, be cautious of. We're okay with turmeric for patients that like to take that for their joints. But when it comes to supplements, the problem we run into, we always try to explain to patients as well, is that there's no way to check any sort of drug-to-drug interactions with them. And they might make your other drugs work better, or they might make them work worse. Making them work better just could mean you have more toxicities to that particular agent. It's particularly if you're on a clinical trial, you'll see us completely delete most of the medications that you're on because we have no clue. We also have no idea when it comes to these supplements, what is it doing to your CLL? We have no idea when these supplements enter into the body, what substance is it? If it's not something that's naturally found in food, but it's in the middle of the jungle somewhere in the Amazon, your body's going to treat that as a foreign substance. So we don't know what's going to happen with the CLL. So it's just the basic food groups that we know we're supposed to be eating. We get a lot of questions on alcohol, of course, moderation. And we do have to have that conversation. What is moderation? Is that a wine bottle per night? Or is that a cup of wine? We tend to say we're okay with alcohol. But if we're starting you out on a new line of therapy, if you can refrain from that for at least 90 days, reason for that, if we see liver enzyme elevations, we want to blame it on the drug, not because we don't know what kind of alcohol your habits are at home, because everything's going to come down to tolerability clinically, as well as what we see in your labs. But there's no special diet. We don't recommend run to GNC. I think the rule of thumb is if there was a cure for CLL, we would know it by now. Somebody would have gotten their hands on it, but there isn't. It's just good old fashioned, what we know we're supposed to be eating that we learned in kindergarten.
Okay. So I have a question here from William Koo. I have recently experienced some episodic hearing loss. Can it be associated with my CLL?
Are you on treatment or are you just on surveillance for your CLL? Oh, watch and wait. Okay. I really wouldn't see, I mean, typically, CLL, yes, CLL might involve lymph nodes in your neck. It's typically not going to, I mean, if it's involving the central nervous system, that's certainly not something we see commonly. If you're having central nervous system issues, that would likely be something different. I don't think the lymph nodes, if they're enlarged in your neck, typically is not going to be associated with hearing loss. I don't know if there's any other cause that you've looked into, if you have an ear, nose, and throat doctor, if someone has checked your ears out. Certainly hearing loss can come from a number of things, from ear infection, sinus congestion, nerve damage. As we get older, we lose hearing to certain frequencies anyway. So there could be a lot of other things going on there. I would certainly make sure you check with both your primary care and your oncologist to make sure you get a good evaluation, just to check your ears out, maybe even send you to an ear, nose, and throat doctor if necessary. But there could be a lot of other things going on causing that. I wouldn't necessarily think it was a direct cause from the CLL, especially if you're just on watch and wait. So your disease is likely not very aggressive, unless anyone else on the panel has seen something different.
I agree. So that was our final question. Panelists, thank you for answering these questions and sharing your expertise with us. You can now go ahead and turn off your camera. Our last presentation has been pre-recorded for this program, but unfortunately, due to technical issues, we are unable to view it on today's webinar. It will be instantly emailed to all attendees after the webinar. It's a very important discussion regarding patient advocacy, access to quality care, pharmacy benefit managers or PBMs, and additional support resources made available through the FLASCO patient portal. So we encourage all attendees to watch it. If you would like to be added to our mailing list for patient advocacy, please email info@flasco.org. I'd like to thank all of our panelists again for presenting this evening and leaving us with this meaningful information. I'd also like to once again thank Pharmacyclics and Janssen for sponsoring this webinar. As a reminder, all of the handouts mentioned in this webinar can be found in the confirmation email, as well as the follow-up email that will be emailed to you following this program. Additionally, this webinar was recorded, so if you missed anything and want to hear it again, it will be available on the FLASCO website. Thank you for joining us tonight, and we hope you will join us for more webinars in the future.